So for everybody out there and everybody in the audience, I want to thank you all. We're here for a new series of program called Compass to MS Care 2. All right, and we're saying 2 because we do have our original series, Compass to MS Care. And Compass to MS Care is about MS Views and News, breaking out all over the United States, providing these kinds of educational programs in rural and underserved communities all about, all right? My name is Stuart Schlossman. I'm president and founder of MS Views and News. I, too, have multiple sclerosis. That's another story. Tonight's program is sponsored by GENENTECH. And in addition to GENENTECH sponsoring it, we want to give them a round of applause and say thank you. So let me hear that. Everybody, great. Thank you. All right, tonight we have a lot of exhibitors. Again, for those that are online watching this, I'm sorry that you're online, but you know, we're here in Atlanta. You could have been here. Could have been maybe here quicker than the people that live here, right? All right, so we have exhibitors. Yes, I heard that. We have exhibitors here tonight. We have people that, we have companies, Banner Life Sciences, Novartis, Bristol Myers Squibb, Janssen Pharmaceuticals, and TG Therapeutics. All right, and so we do want to thank them all for being here as well. Dr. Ben Thrower, most everybody in the state of Georgia knows this person. He's the medical director of the Shepherd Center. I'm going to say it like that, okay? He's the medical director of the Shepherd Center. He's been there for a very long time. We've had people that have worked with him, you know, speak at our programs, but I prefer Dr. Thrower to come down all the time and speak at our events. So he is going to be speaking with you about an array of different things. Thank you very much.
So this is going to be fun tonight. So what we're talking about is just a little bit of everything with multiple sclerosis. When we do MS programs, I realize, you know, looking around the audience, we have people in the audience who are MS professionals. You've been living with MS for a while. You've been to a lot of programs. You've read a lot of things. You know a lot of things. We may have people in the audience who are newer dealing with MS. They may have their support partners here who don't know as much about multiple sclerosis. So we're going to go over some of the basics also, but it's always good to have a little bit of a refresher. So when we think about multiple sclerosis, so MS is an autoimmune condition. It is your immune system gone haywire. So it's a dysregulated immune system. One of the biggest misconceptions that we see in the MS world is that MS is an underactive immune system, and that is clearly not true. It's a relatively overactive immune system. It's an overactive immune system that's picking on things in the brain and spinal cord that it shouldn't be picking on. So even though MS is a neurological condition, really MS is a relative of things like rheumatoid arthritis, lupus, psoriasis, other autoimmune conditions. We'll go into some of the genetics and how some of these similarities kind of play into the genetics as well. So interestingly too, so when I work at Shepherd Center in the MS Institute, the other things that we do at Shepherd Center are brain injury and spinal cord injury. So when you think about those three areas, you're looking at all of the leading causes of disability in young Americans. So if you take trauma out of the picture, multiple sclerosis is the leading cause of disability in young Americans. So MS is incredibly complex. When my wife and I were in medical school, we thought we were pretty slick because we were learning about certain subsets of T cells, and now you're learning about subsets of subsets of subsets of T cells. MS has been compared to a never-ending onion. You peel back layer upon layer upon layer, and that's challenging, as you see from the immunology of what MS does, but realize that every one of those steps in that picture represents a potential treatment opportunity. So anywhere that we could potentially intervene in one of those immune steps represents a way that we could potentially stop the MS pathway. So going way back now, so this gentleman is Jean Charcot, standing in front of an audience of neurologists in 1868. So most of the way that we describe multiple sclerosis, we can attribute to this French neurologist. This painting is actually the size of a large wall mural, and it hangs in the Hospital Salpêtrière in Paris. And what Dr. Charcot is doing is he's lecturing to a group of neurologists. If you were anybody in the neurology world back then, you went and you listened listen to Dr. Charcot talk about things like multiple sclerosis. So at one point, the great Dr. Sigmund Freud, who we think of as a psychiatrist, was actually a student of Dr. Charcot's. So before Dr. Freud was a psychiatrist, Dr. Freud was a neurologist. Most of what we know about pediatric cerebral palsy, the terms that we use like spastic diplegia, were actually terms that Dr. Freud came up with under the guidance of Dr. Charcot. So we're going to fast forward a little bit of almost 100 years. So now we're in New York City, and the very nice lady here, Sylvia Lowry, is speaking with her brother. Her brother had multiple sclerosis, and at that time, there were very few treatments for multiple sclerosis. And she took out the following ad in the New York Times, pleading for help. Anyone who's been cured of multiple sclerosis, please get in touch with me. She didn't get any responses whatsoever. Mrs. Lowry was not a person to take things lying down, so she founded an organization that you may have heard of. She founded the National MS Society in the 1940s. And so that really pushed us into a lot of what we know about MS and having different service organizations, what Stewart does, what the Multiple Sclerosis Foundation does, what the MS Association does, and what the National MS Society do. The National MS Society is still the largest funder of research in the United States for multiple sclerosis. 1993, we get our first FDA approved therapy for multiple sclerosis. I finished neurology training in 1992. We had 0 FDA approved treatments at that time. There's a famous neurologist, Dr. Labe Scheinberg from New York City, who used to summarize the state of MS care as diagnose and adios, because it was a mystery to be solved, and then there was really nothing to offer people with multiple sclerosis. So in 1993, we get our first FDA-approved treatment in beta-seron. I don't know if you how many of you were dealing with MS back then. What a strange time. We had the first FDA-approved treatment, but there was not enough of the beta-seron to go around, so they had that very odd lottery system. So people with MS went into a lottery, and if you had a number of 1 to 10,000, you got beta-seron. If you had a number above 10,000, you waited for your beta-seron. 2022, we have more than 20 FDA-approved therapies and a lot of things coming down the line. So, big picture, this is the way a myelinated nerve fiber in the central nervous system should act. So the yellow is the axon, the wire that's going to transmit electrical information. The blue is the myelin. And you have these gaps in the myelin called nodes of Ranvier. Ranvier was also a famous French neurologist who worked with Dr. Charcot, and he said the way that these gaps work is the electrical information jumps from gap to gap to gap. Very fast, very efficient way to get information to and from your brain and spinal cord to the rest of your body. Unfortunately, multiple sclerosis comes along and it's going to chew up that myelin. It's going to mess up that electrical conduction. And if you had asked a neurologist up until 1998 to describe what MS does, their story, our story, would have stopped right here. We said MS just damaged the myelin in the brain and spinal cord. But then Dr. Bruce Trapp at the Cleveland Clinic said, you know what? It does more than that. It actually cuts the wire. It cuts the axon, and that was a big deal because we know that the body can still conduct electrical information with damaged myelin, but if you cut the wire, there's no information at that point. And Dr. Trapp showed that this damage, this cutting of the axons, occurs fairly early in MS. It was right after this paper came out that the National MS Society issued their first consensus statement on early treatment for MS. They said we really can't be taking a wait-and-see attitude. We need to get MS diagnosed quickly, and we need to get people on treatment also quickly. So when we think about where MS occurs in the world, so your areas in blue are areas where we tend to see more multiple sclerosis. So we've always thought of MS as being more common as we go away from the equator. And there's certain areas of the world where we just don't see as much multiple sclerosis. So like the continent of Africa, certain parts of Asia, we just don't see a lot of multiple sclerosis there. Interesting study that just came out this spring. So I was taught in medical school that MS was much more common in white people, that it was, if you had to describe a prototypical person with MS, that it was going to be a blonde, blue-eyed, 30-year-old white person. And this paper and some of what we're seeing in the real world have really challenged that idea. This study out of California showed that in their patient population that there was no difference in the incidence of MS between white people and black people. Still, if you go to the continent of Africa, if you remember the map that I just showed you, we don't see a lot of MS in Africa. Is it because countries like the United States are melting pots and we're genetically sort of all, blending with each other? Or is it because the medical systems in places like Africa just are not recognizing MS? Are we underdiagnosing MS in places? And is it really just as prevalent there? We don't know the answer to that. I will say if you come to Shepherd Center, 50% of our patient population that we're working with are African American. So we certainly are seeing a high prevalence here in Atlanta. So there are a lot of things that come together to result in multiple sclerosis. There are genetic contributions. So we know of over 200 genes that put a person at risk for MS. You could have every one of those genes. You've inherited all of them, and you still may not get multiple sclerosis. Something environmentally has to trigger that. And some of those environmental triggers are things like common viruses. We've known for decades that Epstein-Barr virus is linked to multiple sclerosis. Researchers at Stanford University in January took it a huge step forward and showed us how it's linked to multiple sclerosis. What the researchers at Stanford found were the amino acid sequences on the surface of Epstein-Barr virus that your immune system is reacting to, the antibody that is being produced, and what that antibody is attacking in the brain and spinal cord. That is a huge leap forward in our understanding of what Epstein-Barr virus does, and it could lead to big treatments. You could imagine, if we know what's going on here, what if we could develop a monoclonal antibody that maybe blocks that receptor on the Epstein-Barr virus, or that binds to that antibody that's being abnormally produced. So hopefully big things will come of that research. There are a lot of other environmental factors that play into the risk of multiple sclerosis. We know that 85% of people with MS have low vitamin D levels, and that vitamin D plays a much bigger role than just bone density regulation, that it plays a big role in the immune system. Low vitamin D levels tend to equal low numbers of T regulatory cells. T regulatory cells are good guys in multiple sclerosis. You want more of them, and if your vitamin D levels are low, you're going to have lower levels of these T regulatory cells. Things like obesity, interestingly, especially in teenage girls, has been linked to a higher risk of multiple sclerosis. Salt intake, high cholesterol levels, cigarette smoking, all these things are just little environmental factors that increase the risk of MS in the genetically susceptible individual. So when we think about managing multiple sclerosis, it doesn't matter if you're a doctor, a nurse practitioner, a physical therapist, occupational therapist, everything that all of us do in managing MS fits into one of these three boxes. We're either treating relapses, we're managing symptoms, or we're changing the course of the disease overall. Hopefully, at some point in the near future, we're going to have a fourth arrow on this diagram, and that's going to be reversing the disability, actually repairing damage and reversing disability. And we'll talk about some research that's going on. We could spend hours in any one of these three boxes. I'm just going to touch a little bit on the symptom management and a little bit on altering the course. So some of the common MS symptoms we deal with are things like visual symptoms, sensory symptoms, motor symptoms, bowel and bladder symptoms, walking issues. And again, we could spend lots of time in any one of these areas. Stuart knows I have certain favorites that I like to talk about. So one of my favorites is talking about walking issues. When you survey people with multiple sclerosis, especially right after they're diagnosed, what is one of the biggest fears that people with MS have? It's losing my walking ability. And so when we think about walking ability, there really are 5 ways that multiple sclerosis can potentially affect your walking. We can have increased muscle tone, spasticity, spasms, very common in multiple sclerosis, foot drop, so just the inability to get your foot up off the ground, nerve fiber fatigue. I get overheated or I exert myself and I start off walking or doing a task at a certain level, and the hotter I get or the longer I do it, the harder it is to do that activity. That's called nerve fiber fatigue. Sensory ataxia, we'll touch on for just a second, and then cerebellar dysfunction. The cerebellum is the primitive part of our brain that controls how much we move. So if you have cerebellar issues affecting, say, the left hand, when I go to reach out and grab something, the closer I get to it, the harder it gets to stop that movement. So you may have normal strength, you may have normal sensation, but you cannot control how much you move. Wanted to just focus on two of those areas, foot drop and sensory ataxia. The reason I focus on those is because I think those are the most common things that mess up people's walking in MS. And foot drop can be sneaky. So your ankle dorsiflexors, or the muscles, are going to get your toes up off the ground. If you had to pick the two weakest muscles in the legs in a person with multiple sclerosis, it's going to be your ankle dorsiflexors and your hip flexors. If you have foot drop and your hip flexors are intact, you would do something called a steppage gait. Steppage gait means you bring your knee up higher so that you're not going to catch your toes on the ground. The problem in multiple sclerosis is if your ankle dorsiflexors are weak, your hip flexors are probably weak, you can't do a steppage gait. You can't bring your foot up high enough. So what you end up doing to compensate is called circumduction. You swing your leg out and around. A lot of people with MS are not even aware they're doing it. One of the things I challenge family members or friends of the person with MS is I say, when they're walking, so let's say you're in the mall or you're out in the neighborhood and they think they're doing okay, as they start getting a little bit tired, watch their walking. Watch them walk from behind. And what you'll probably see is that weaker leg swinging out and around. The problem with doing circumduction is now you're using muscles to walk that you weren't designed to use, and people fatigue very quickly. That circumduction pattern also puts a lot of stress on your knee, your hip, your lower back. It's just not a normal pattern for walking, so people fatigue very quickly when they're doing that. Traditionally, if we send you to a physical therapist and they notice some foot drop, they're going to prescribe an ankle foot orthotic for you. This is the rigid L-shaped brace back of the calf under the sole of the foot. And these can do wonders for some people. A lot of people don't like them, though. They don't fit in the shoes they want them to fit in. They're visibly obvious to other people. Well, folks say, well, I want to wear shorts, but I don't want people to see my ankle foot orthotic. So a lot of ankle foot orthotics end up sitting in the closet and not getting used, and people drag them out when they go to the doctor's appointment just to make us happy. Don't do that. If you have an ankle foot orthotic and you don't like it, tell somebody. There are other options out there. There are some over-the-counter devices that you can use. One that we like quite a bit is called the Sabo device. It's a little collar around your ankle with some steel, very fine steel cables that clip into your shoe. Super durable, inexpensive. For some people, that may be what they need. And then we have some higher tech devices like the Bioness device, Walk Aid, and then a device that just got FDA clearance called the Neural Sleeve. All of these devices in the last bullet are examples of functional electrical stimulation. We're not putting a brace on your leg, we're rewiring your leg. So we're stimulating the peroneal nerve on the outside of your knee and making your foot work again. The question has always been with that sort of technology, how do we make it actually work for you? How do we make the foot come up when you want it to come up? So really, I can sit in an exam room with someone and say, I bet this person would be a great candidate for one of these devices. It really takes getting in with a physical therapist and letting them put those on you and see if it does what you want it to do. The last device there, the Neural Sleeve, is brand spanking new. It's not commercially available until this fall. It looks like a black neoprene sleeve. It starts at your ankle and goes up above your knee, and it's got the nerve stimulator built into it. Hopefully that's going to be a nice tool for us to have. No idea on pricing. I can tell you the other two devices, the Bioness and the Walk Aid, are pretty pricey. The Bioness device, if you use the base cuff and the upper cuff, can be as much as $8,000. So it's really important that we make sure that this is going to do what you want it to do, and then try to go and find a way to get it paid for you. Sensory ataxia. So ataxia means you walk like you've had a drink too many. Thus the t-shirt, I'm not drunk, I have MS. We have one of our patients who likes to wear that shirt. Her husband wears the shirt that says, I don't have MS, I'm drunk. Ataxia, you're walking like you've had a drink too many. Sensory means you do it because you can't feel changes in position in your feet. Every joint in your body has a position receptor. If you close your eyes and move your finger up or down, you should be able to tell. I'm not looking, but I can tell it's moving up or down. In multiple sclerosis, those position receptors are not working as well as they should, especially in the feet. So people can't tell if they're tilting one direction or the other. So a lot of people with MS walk like they've had a drink too many. Feet are going to be wider apart. People know where the furniture is. They know where their significant other is. What your brain is going to try to do to make up for that loss of position sense is use the visual horizon. So you're going to look out at the horizon to tell if you're tilting one direction or the other. Don't do things when you're walking that take your visual horizon away. If you're standing in the shower with your eyes closed to wash your hair, you're pretty high risk for falling if you have sensory ataxia. And as many of you know, there's nothing soft to land on in the shower. If you're walking with your friend and you're having a conversation, looking at them and not looking out at the horizon, it's almost bad as closing your eyes and walking. So when you're walking, and if you have balance issues, take advantage of the visual cues that your brain's trying to use. So what do we do to treat sensory ataxia? We'd love to get you in with a physical therapist and have them really work on your balance. Anything that we do for core strengthening tends to help them with your balance. It doesn't fix the lack of sensation, but what it lets you do is adapt to it a little bit more quickly. How many of you are familiar with Hippo Therapy in the room? Really, so one in the back. So Hippo is Greek for horse. So this is horse therapy, not therapy on a hippo. That would be interesting, but that's not what we're doing. So if we put you on horseback and you have balance issues, and now we have you go around an arena in a safe fashion, when that horse is walking, your pelvis has to move with that horse just like you're walking. You're being forced to use all of these core muscles to stay upright and keep balanced. This is one of the greatest ways to improve balance in people with MS, spinal cord injury, stroke, traumatic brain injury. Obviously, it's not widely available. We do have a couple of different facilities in the metro Atlanta area. A lot of hippotherapists are physical therapists. And so if we send you to Hippo Therapy and that facility is using a physical therapist, your insurance will pay for it as physical therapy. The facility at Chastain Park here in Atlanta is one of the most accessible I've ever seen. I don't care if you're using a cane, a walker, a power chair, a scooter, they can get you on horseback and do it safely. So to kind of little esoteric form of therapy to improve your balance, but kind of keep it in mind. And then adaptive equipment. So if you're having balance issues, maybe we need to think about, a quad cane, something to give you a good base that if you do start to tip, you've got something to lean on. I wanted to put this under the symptom management section because this is where it fits best. If we do talks on cannabis and multiple sclerosis, this is an area where we usually get a room full of people because it's an area that people are very interested in. So the active chemical ingredients in cannabis, and when we say cannabis, we really mean two plants. We mean the hemp plant and we mean traditional marijuana. The difference between those two is, both of these plants have been around for thousands of years. As hemp was bred, primarily in colonial times, it was bred to have more of a thick stalk and less leaves. They did that because they wanted rope, to make rope from the hemp stalk and to make paper from it. In the process of doing that, they bred out some of the genes that make delta-9 THC, which is one of the cannabinoids. So when we think about hemp plants make a lot of CBD. They don't make as much delta-9 THC. Traditional marijuana plants make both. So what does the science say on using cannabinoids, CBD and THC for MS? There's good data out there for managing spasticity and spasms, for managing overactive bladder, and for treating central neuropathic pain, burning, hypersensitivity. One of the challenges with using cannabinoids is you need to know what state you live in and you need to know what your state laws are, because we are unfortunately a patchwork of different laws from state to state to state. The Hopefully we will get to a point when we have some FDA approved treatment options. There is research going on throughout the United States with nabiximols or Sativex. This would be an FDA approved form of cannabinoids. It's a 1-to-1 mixture of CBD and THC in a sublingual spray. It's approved in approximately 23 other countries around the world for managing spasticity and spasms in multiple sclerosis. So again, you've got to, if this is an area you're interested in looking at, speak with your healthcare team, know what your local laws are. One area that research has not given us the answer to yet is cannabis useful for treating MS overall? Can we change the progression of multiple sclerosis with cannabis? The reason we're interested in looking at that is every cell in the immune system in the human body has a cannabinoid receptor. It's called a CB2 receptor, and they appear to be anti-inflammatory. So it's not too far of a stretch to say, well, we would think that some of the cannabinoids should have potent anti-inflammatory effects. The challenge in MS is no one's been able to prove it yet. And it may be that we're looking at a tough group of people with MS. A lot of the studies looking at cannabinoids as disease-modifying therapies have really looked at secondary and primary progressive MS. Those are tough. Those are tougher forms of MS. So I would say stay tuned. It's an area you'll probably hear more about going forwards. So shifting to altering the course of MS, and again, we could spend hours on this. When you think about choosing a disease-modifying therapy, there are a lot of considerations. You need to think about what is important to you. What is your risk tolerance? Are you looking for an oral medication? Are you willing to do an injectable? Are you looking for an IV medication? If you're looking for an IV medication, how willing are you to go to that infusion center? We have infusions that are once a month, once every 6 months, in between those things. So these are all things that you need to help us with. Ultimately, we, as a healthcare provider, I may know what I would like to choose for you, but it's got to fit your lifestyle. And you need to tell us, what are the most important things? Is it effectiveness? Is it safety? Have you tried other things out? Have you talked to other people? I think one of the most important messages we try to give people as well is, as you're talking to others in the MS community, realize that your MS experience is your MS experience. How one person does with a medication may not be how you do with a medication. So it's nice to exchange information back and forth and hear other people's stories, but realize just because Mr. Smith did great with drug A doesn't mean you're going to do great with drug A. So you've got to really chart your own course. What are we trying to do with these disease-modifying therapies? Well, number one, we want you to tolerate it. We want it to be a fit for your lifestyle and for you to be happy with it. If I put you on drug X and your MS is really well controlled, but you have horrible side effects, I may be happy, you're probably not going to be very happy. And so you've got to have good tolerance for whatever we choose. And then we would like to prevent relapses. We would like to prevent progression of disability, and we would like to prevent new MRI lesions. If you put those three things together, there's an acronym out there called NEDA, N-E-D-A, no evidence of disease activity. NEDA means you're getting an A+ on your MS exam. It means you have no relapse, no progression of disability, and no new MRI lesions. Some people use a term called NEDA4, well, they'll add a fourth parameter, and that would be no atrophy on MRI over time. But this is what we would like to see. And I would argue that as we're here tonight in 2022 with over 20 FDA-approved treatment options, if we have a newly diagnosed individual, it's not unrealistic to say we really want you to have an A+ on your exam. We have enough treatment options to pick from that's really what we should shoot for. That's very different than when back in the days when we really only had ABC. We sometimes achieved NEDA with the ABC drugs back in the day, but for a lot of people we didn't. And sometimes there was this kind of therapeutic nihilism that we're just not going to make people stable, and this is the best we can do. And I think that's a dangerous attitude to have now with all of the treatment options that we have. So you'll notice one thing that's not on the treatment goal list, and that's in yellow. Symptom improvement is not a treatment goal. These medications really are not designed to make you feel better. Some people get lucky on these drugs, and they do have symptom improvement. We'll take that when we get it. Do I think that these medications are directly repairing anything in the brain and spinal cord? Very unlikely. What they may be doing in some people is so effectively stopping the inflammatory process that we're letting natural repair mechanisms or natural neuroplasticity or rerouting of pathways take place so that there is functional improvement. And we'll take that, but it's probably not the medication directly. So if I have an individual come in and they have baseline symptoms and we put them on one of these medications and they tolerate it, and I see them 5 years later and they say, you know what, I'm exactly the same. I'm thrilled. That person may still be dealing with those same baseline symptoms. They may have walking issues or cognitive issues, but if they've not progressed any, that's a success. If we can draw the line in the sand and keep people stable right now and let technology catch up to them to give them that repair option in the future, that's a success with any of the drugs in the disease-modifying care therapy class. So our toolbox has gotten bigger over the years. So these are all the FDA approved treatments that we have right now. Again, it's an interesting dialogue in newly diagnosed individuals. I would argue that probably most MS centers, when they sit down with an individual, we have some treatments that we like better than others. I will mention all of these to a newly diagnosed individual. I want that person to have heard of all of them, and then I'll say, here's the ones I would probably take off the table, and these are the ones that I would have you focus on. And I'll tell the person, this is why I think these might be the most appropriate for you, but then get feedback from them. Does this fit with where you want to go? We used to joke back in the ABC days about 3 kits and out. The healthcare provider that handed the person 3 kits of information said, go home, read these, come back in 2 weeks, tell me which one you want. That is an abdication of our responsibility. Our job is to be guidance counselor and to help people sort of make an educated choice. Ultimately, it's their choice, but us just handing them information. Now, if we handed them all of that information, I mean, the person's brain would probably go numb as they tried to take all of that in. So we also have to be willing to admit that when we choose a therapy and we set out on a certain path, it's not always a perfect path, and that we don't always get that A+ on the MS exam with the first try. So if the person is not having perfect disease control, if they're having breakthrough relapses, progression of disability, new lesions on MRI, we have to be willing to change course. I think one of the toughest things to sort out is that progression of disability. So every day in every MS center in the United States, there is a discussion that sounds something like, well, doc, you said my MRI is stable. I'm not having any relapses. I'm on a treatment. I'm on a treatment that you say is very effective, and I'm still getting worse. And that's a challenge. We believe you when you say you're getting worse. And one of the challenges that we have is what's driving that progression. Is it truly the underlying MS that's worsening, or is it something else? And that something else that we're starting to wrap our head around is loss of neural reserve. Neural reserve is our brain and spinal cord's ability to be injured and adapt to it and still get over it. And all of us as humans start losing some neural reserve after about age 30. Kind of intimidating to think about it, but all of our brains start shrinking a little bit at age 30. And so in the individual without multiple sclerosis, maybe what that looks like is, as a 60-year-old, I still think I can run as fast as I could when I was 20, and then I try to do it, and my body says, no, you can't. That's just normal human aging. Well, now if you have underlying injuries in the brain and spinal cord from multiple sclerosis, that loss of neural reserve, maybe that MS lesion that was giving you this much trouble is now giving you that much trouble. The lesion didn't change. The underlying pathology of your MS didn't change. What changed is your brain's ability to adapt to it. So you've lost reserve. So as we lose reserve, I do think there's the potential that people see some progression of symptoms. And I don't know that changing therapy in that setting is going to make that much of a difference. And it's something we're really struggling with. How do you tease that out? You know, what is true disease progression from MS and what's progression from loss of neural reserve? If we think someone is losing neural reserve, we do know that getting people in a good reconditioning program, getting them in with a physical therapist, regular exercise does make a difference, that we can restore function. Ultimately, though, what that loss of neural reserve speaks to is the need for repair strategies. We need things that are going to remyelinate, reroute pathways, improve neuroplasticity, and hopefully, again, we're going to be having that discussion at some point in the near future. So when we think about this toolbox of treatment options, I'll just throw one other concept up, and that's when you're working with your healthcare team, whether they state this or not, they're working from one of two paradigms in the way we think about how we would like to choose one of those treatments. People either do what we call escalation therapy. And what escalation therapy means is I'm going to choose a therapy for you that has modest efficacy but great safety. So I know this drug is very unlikely to cause big bad side effects, and it may help you get that A+ on your MS exam, but it's not as effective as maybe some of the other things. If this drug does what we want it to do and you achieve NEDA, then great, we're happy. If it doesn't, I'll move up. I will escalate my therapy to the next rung. The alternative to that kind of thought is called induction therapy. And with induction therapy, I'm going to choose the most effective therapy I can, maybe one that carries more side effect risk, and I'm going to manage that risk. I want to put your MS fire out as aggressively as I can, as early as I can. I would argue that most MS centers in the US and Canada are probably going to fall into that induction therapy. We like to pick more aggressive therapies while at the same time being very obsessive about managing the risk and choosing the appropriate, highly effective drug for the right individual. Not all community neurologists, but I think if there was a bias, I would say more community neurologists are maybe in that escalation therapy. You know, they're not working with large numbers of individuals with MS. The thought of managing the risk of some of the more effective therapies is a little scary. They don't have an infusion center. They're sending those infusions out to, a cancer center or another infusion center. So just kind of be aware that there are these different paradigms for how we choose from that toolbox. So if we're thinking about a highly effective therapy, I'm going to spend just a couple of minutes on autologous hematopoietic stem cell transplantation. So this, I would argue, is probably potentially one of the most effective therapies that we could throw at a person with MS. So if MS is your immune system picking on something that it shouldn't be picking on, what if we just gave you a new immune system? We just cleaned your hard drive, we reboot your computer with a fresh immune system, and we start all over again. So people with MS have had this inadvertently done through bone marrow transplants. If a person with MS develops lymphoma or leukemia and they get what we call an allogeneic bone marrow transplant. Allogeneic means you're getting someone else's cells. My brothers, my sisters, my parents, closely matched donor. So if I get that person's immune system, I no longer have my immune system. I have that person's immune system, and their immune system doesn't have MS. So you can treat MS by doing that. The downside to an allogeneic or a matched donor is that's not your immune system, and you always have to be on some type of mild immunosuppressive drug to prevent what remains of your immune system from rejecting that. So you're always on some low-level immunosuppressant drug for life to prevent that rejection. Autologous means they're your cells. So we're taking immature cells from your bone marrow, cells that can become any part of your immune system, wiping out your existing immune system and giving you those immature cells back and letting you reboot a fresh immune system. This can be very effective. It's not a risk-free procedure. How do we clean the hard drive when we do this? It's high-dose chemotherapy. So it's called immune ablation. We have to do high-dose chemotherapy to kill your existing immune system, and those chemotherapies don't come without risk. Those chemotherapies have long-term side effects. We may not see side effects for 20 years down the line with high-dose chemotherapies. There is also a point in time where you have no immune system. We've wiped out your immune system with the chemotherapy, and we're waiting for that fresh immune system to take hold. And that usually takes at least 30 days before it starts. So there's a period of 30 days where this individual is going to need to be in a bone marrow transplant unit. Any little infection that comes along could be potentially a serious complication. We've learned a lot about this procedure over the years. What we've learned is that there really is an ideal person for this. Not everyone with MS is an ideal candidate. Because of the risk of the procedure, you really want to be thoughtful in choosing who might undergo this procedure. The ideal person for this is going to be under the age of 50. They have relapsing remitting MS. They've got hot disease. They have a head full of active inflammation. They've got active relapses. And they've probably tried a treatment or two that hasn't put that fire out. That's going to be your ideal candidate. The person with long-standing primary or secondary progressive MS is probably not the ideal candidate for this. Things have gotten very interesting. So Northwestern in Chicago was one of the largest research centers for HSCT, and they're on hold right now. So there may be one or two other research programs going on looking at HSCT in the United States, but they're pretty few and far between. So right now, if a person with MS wants to pursue HSCT, they're really left to going overseas. Our two major centers that were a lot of our patients were going to were either Mexico or Russia. I suspect Russia is not an option at this point, just due to what's going on in the world. So that leaves us with Mexico. So there is clinical Ruiz in Mexico. They are well-trained physicians who are doing this procedure. My criticism of clinical Ruiz in Mexico is they are indiscriminate. They are not following this guideline. If you go down and you have the funds, and let's say you're 65 years old and you've had secondary progressive MS for 15 years, you've been non-ambulatory for 10 years, they're going to transplant you. They will do it. They are not putting people in a bone marrow transplant unit. They have a very clean, very modern apartment with very well-trained nurses, but it is not a bone marrow transplant unit. You're going to be there for about 30 days, and then you're going to get on a plane and come home. If you have a complication here in Atlanta and the person who did your transplant is back in Monterrey, Mexico, it's very unlikely you're going to get on a plane and go back there to treat that complication. So it's really something people need to think about. I encourage people that are thinking about doing this procedure to maybe talk to a hematologist in their hometown to have a backup in case there are complications. Because in the States, this would typically be a procedure that's done through a hematology oncology group. So what about that fourth arm of treatment, neural repair? Is it going to happen? Hopefully so. And realize that this is not just a goal for multiple sclerosis. This is a goal for stroke, brain injury, spinal cord injury. So you have researchers around the globe who are just dedicating their lives to repairing this damage. It wouldn't surprise me if the answer for neural repair might not come from the spinal cord injury world, because you think about the world they live in, they have a one-time event. They have one site of injury. They don't have an ongoing process that they have to worry about with disease-modifying therapies. Their whole focus is rehabilitation and restoring function from that one injury. So when we look at some of the stem cell research that we're doing, sometimes that's also occurring in the spinal cord world. So Shepherd Center is one of 3 sites in the United States that is doing a mesenchymal stem cell trial. We talked about the bone marrow transplant stem cells just a second ago. So that's one type of stem cell. These stem cells, mesenchymal stem cells, you don't have to wipe out your immune system. Mesenchymal stem cells are immature cells that can become a lot of different parts of the human body. They're given typically intravenously. Some studies in MS have looked at them into the spinal fluid. So Shepherd Center is partnering with a group called MSTEM or IMSTEM. This This was research that was originally done at the University of Connecticut. They developed this cell line, and it is early. It's a phase 1 trial. So we have infused 5 individuals at Shepherd Center. The last time I checked, Rocky Mountain and MS Center in Salt Lake City had either done 2 or 3. And then there's another center in Boston that, to my knowledge, has not infused anyone. So in the first arm of this study, we'll be doing a certain dose of these stem cells, one-time infusion. There's no placebo group. Everyone's getting active treatment. In the second arm, we will do a double dose of those stem cells. In the third arm, the individuals will get 2 double doses of the stem cells, assuming that no safety issues have occurred prior to that. So this is the type of research that is going on around the country. One of the other areas that I think is very interesting is looking at repurposing FDA approved drugs to see if they might actually repair damage in the brain and spinal cord. So the National MS Society helps develop a technology called micropillar arrays, and that's on the bottom part of the slide there. So a micropillar is a fake nerve fiber. It's a fake axon in a test tube. Myelin can grow on this artificial nerve fiber. So in that test tube, you're going to put some sort of solution that would support cell growth, and you're going to add a cell called an oligodendrocyte precursor cell. This is a cell that wants to grow up to be an oligodendrocyte and make myelin, but something has to turn it on and tell it to make myelin. So you've got thousands of these test tubes with the fake nerve fiber, an oligodendrocyte precursor cell, and now you're going to start adding medications. In this tube, I'm going to put Zantac. In this tube, I'm going to put Prozac. In this tube, I'm going to put something. So these are drugs that are already FDA approved. They have a known safety profile. And you're going to see, but just by luck, you might grow myelin in that cell. You don't know why this medication would turn on an oligodendrocyte precursor cell. You just know it does in the test tube. The beauty of this model is you already know the medication is safe. You don't have to do animal studies. You can jump straight from that test tube where you've got a positive result into human trials. And so clemistine is something that has come out of this research. Clemistine is the active ingredient in Tavist. It's an antihistamine. Why in the world would an antihistamine repair myelin? We don't know. We'll figure that out later. We just want to show that it does. So there is one completed study in 50 individuals with MS where they did show recovery of visual function in people with optic neuritis, and now there's a much larger study going on. So these are the kind of things where you could see fairly rapid advances because you've got this very quick screening method to move things along through research. MS and COVID, again, the topic that we could spend lots of time talking about. You know, we've all been through the COVID pandemic, and it obviously touched a lot of individuals, sometimes in tragic ways for different families, but it meant something different to the MS community. So in general, assuming you're not on a treatment that suppresses your immune system, people with MS generally were not at higher risk for COVID. But with some of our therapies, we could change that dynamic. So some of our B-cell therapies, our Ocrevus, Kesimpta, Truxima, Rituxan drugs, were associated with a higher risk of hospitalization, ICU stays, and death in individuals who contracted COVID. Then we get into how people with MS respond to vaccines. So in general, we do recommend vaccination for people with MS. In general, vaccines, the COVID vaccines have proven safe for people with multiple sclerosis. That said, you know, we're talking about large populations of a variable disease. If you go online, you can find people who said, man, I got a COVID vaccine and my leg numbness got worse. We can always find those individuals, and we don't discount that. We know that there are people who have side effects to vaccines. But in general, the benefits of the vaccines outweighed the risk of the vaccines. The challenge was that some of our medications resulted in a lower antibody production after vaccination. So our B-cell therapies and our S1P modulators, so Gilenya, Mayzent, Ponvory, and Zeposia, were associated in studies with lower antibody production to vaccination. So how do we get around that? Well, one way, if you're on a B-cell therapy or maybe you were starting one of the oral S1P drugs, is to try to do the vaccines before you start the medication. The other way that we've gotten around that is by using a product called Evusheld. So Evusheld is related, it's in the same class as Regeneron. These are COVID monoclonal antibodies. So that rather than giving you a vaccine and asking your immune system to do something, make an immune response, we'll just give you the passive antibodies. Your immune system doesn't have to do a thing, and we know you've got good antibody levels then. We like the Evusheld product better than the Regeneron product because it seems to have better Omicron coverage. So we are offering Evusheld to any of our patients who are on a B-cell therapy or one of the S1P drugs as a passive way of protecting yourself. 2 weeks ago, the FDA authorized second doses of Evusheld at a 6-month interval. So if you're on one of those therapies and you don't know if it's important, talk to your healthcare team. We can do blood testing. If you've been vaccinated and boosted and you don't know if you have a good antibody response, we can do a blood test and tell you whether you've got it. I will tell you in our experience, especially with our B-cell therapy patients, most of our B-cell therapy patients did not make a good antibody response. That doesn't mean they didn't get benefit from the vaccine, because remember, the vaccines don't just do antibody production, they make a T-cell response also. So what research has shown is that everyone on either the B-cell therapies or S1P therapies made good T-cell responses. The problem that we have with T-cell responses in the clinic is we don't have an easily available blood test to measure a T-cell response. We have great blood testing for the antibodies, but not great blood tests for the T-cell responses. So again, Evusheld, nice addition to have out there and a way of offering people passive protection. So wanted to finish up with just talking about kind of the big nature of accessing care for your MS. So MS requires an army of people to really do it right. One of the things I realized early in my MS career is that the neurologist was an important piece, but was far from being the only piece, that this whole other team was really required to do MS right. You may live in an area like Metro Atlanta where you have access to Shepherd, MS Center of Atlanta, Emory University. So you've got 3 comprehensive MS centers in the Metro Atlanta area. If you don't live in an area where you have a comprehensive MS center, you may have to kind of recreate this team and sort of a center without walls. And that's done commonly throughout the United States, where people say, well, I don't have a place where I can go where it's all under one roof, but I know that if they're working with my team or working with different nonprofits like the National MS Society, I can put this team together for myself. So realize that when we think about how we chart your MS course, it is a partnership. And so again, it really shouldn't be the old days where the doctor was telling you what to do. It shouldn't be that kind of relationship. It really should be a kind of a give and take. Us saying, okay, here are the options. You tell us what symptoms are bothering you. What are the issues? We're going to lay out all the different options for you. Maybe you don't like to start new medications. Maybe you want to keep your medications to a minimum, and so we're going to work in that kind of paradigm. Maybe this symptom is worse than that symptom. We're going to go after that first. One of the things that Stuart has helped put together through his organization is a pre-healthcare visit list that you can find on their site that helps you organize your thoughts. It helps me a lot if a person comes in and they've got a good medication list. I always like to make sure that what I've got in your medical record matches with what you're actually doing. And then if you have your problem list, tell us what are the things that are bothering you, and always, always, always put your most bothersome symptom first. It sounds silly to say that, but we'll have people that we spend 30 minutes talking to, and we've gone through 8 different symptoms, and they'll go, and we're out of time. And they'll say, now let's talk about the thing that really bothers me. It's like, oh, why didn't we do that one first? Why are we waiting till the last? So help us out, and come really prepared for your visits. And again, you should be at the center of this whole discussion. You've got an army of people working around you. Just make sure that your needs are getting met, and we do that through communication. And with that, I think Stuart is going to mask up and go around with the microphone. I really appreciate your attentiveness, and let's see what thoughts or questions you guys have.
Thank you very much, Dr. Thrower. Anybody want to thank Dr. Thrower? I think so.
Thank you.
By the way, yes, I did say earlier that if you have any questions, I'm going to come around. I'm going to have a mask on. I need you to have a mask on as well, all right? But what Dr. Thrower was referring to with the MS Views and News on our website, we have that tool that you can print out in advance, and basically everything that's on that 2-page tool, it's just paper, all right? It's not a screwdriver or anything like that, all right? But you can fill that out before going to your neurology appointment, and that will be able to, that will give everything to your doctor or nurse practitioner that they're going to need to know what's wrong with you that day, so that way you don't find that swinging door on the way out where you forgot to ask a question. Fill that out, a week before you go there, and you'll be happier that you did, and your clinician will be happy you did as well. So firstly, I got a lot of questions online. We got like 40 questions online. Hopefully some of them are just repeats so I could skip over them, all right? But others, how about you all? Do you have any questions? How about this big guy up front? You got any questions? No? Okay, well, I'll have to go to the young lady behind you.
In regards to the Evishield, that is a vaccination, and is that correct?
No. So Evishield is not a vaccination. So it's passive antibodies. By definition, if we give you a vaccine, we're asking your immune system to respond to it and mount an immune response. With the monoclonal antibodies like Evishield and Regeneron, we're not asking your immune system to do anything. So it's just passive protection.
I've been seeing a lot of things online talking about different clinical studies and things like that. How do you vet those to decide whether you should apply to them or
Yeah, so there's vetting that occurs on your end and on our end. So most MS centers, so we probably get offered 2 studies per week, and I would say we end up accepting maybe 10% of the studies. So when we look at a study, one of my questions is, does it benefit the MS community? Is this something that the average person with MS would want to participate in? And ultimately, is it something that I would put my family member in? Is it something I would participate in? The next kind of check is at the institutional level, whether it's Shepherd or Emory or wherever, there's something called the IRB, the Institutional Review Board. So this is a panel of healthcare providers, spiritual leaders, priests, rabbis, ministers, people with MS, people with spinal cord injuries, who look at the studies and they grill us. So I come in as a principal investigator and say, I really want to do this study. And they will look at it and say, well, what's the risk? Have you thought about this? And then so they have to sign off on it. If you are thinking about participating in a clinical trial, you really want to make sure that that research coordinator has sat down with you and explained the risks and benefits, and they will have an informed consent. You can take that informed consent home and spend a week with it, reading it. There should never be any pressure for you to participate. The big things that I would look at if you were looking at clinical research is it a placebo-controlled trial? If you're talking about a placebo-controlled trial and we're managing fatigue, well, there's no big risk to not being on a treatment for fatigue. That might be a hassle. If you're talking about a placebo-controlled trial in relapsing remitting MS, there's risk to that. Not treating your MS is risky. So just make sure that you've really looked at it, and take your time, ask lots of questions, and think about the different phases of research. So phase 1 would be the earliest clinical trial available. That means that these are the first humans who've received this treatment. It was only animal or laboratory. By the time you get to phase 3, which is what most people would likely be participating in, there's some human safety data that's been through the mill a little bit. And then phase 4 is what occurs after it's already FDA approved, and they're just asking additional questions after it's already FDA approved.
When you mentioned that professionals like to get to the NIDA, all right, is there any particular time frame that you go by of somebody's state, relapse-free, all the things that you mentioned that, were doing good? Is there a particular time that you would give to stop the drug altogether?
Yeah, so ideally you'd like to, if you start a therapy or you're switching therapies, you'd like to give it at least a year. There are exceptions to that. So if you have a head full of active inflammation and I put you on a drug that I know should put that fire up pretty quickly, and now 6 months into it, you still have a head full of active inflammation, I'm probably not going to wait a year in that setting. But outside of the kind of extremes like that, generally you'd like to do a year. What we want to avoid is something that some people call churning, where you go through a lot of treatments really quickly, and now you look back over them and you go, did we really give that one an adequate chance? And then you end up re-challenging someone with something they've already been on, that you don't like to have to do that. Yeah.
Is there a timeline that should be discussed when wanting to do a vaccine versus when to take their Ocrevus? So
ideally, you'd like to put some time between your Ocrevus and the vaccine. And it's not a safety issue. It's trying to maximize the benefit you're going to get from the vaccine. So the problem is you don't want to be too soon after an infusion, but you don't want to be butting up into your next infusion too. So because most people are on every 6-month infusions with Ocrevus, we've usually said somewhere in the 3 to 4 month range to get your vaccines done. Ideally, again, if you're thinking of not yearly vaccines, but maybe you're due to update your MMR or something, ideally, if you can, you'd like to think about getting those vaccines before you even start Ocrevus.
Okay, thank you. Dr. Thoreau, before I ask the next question, there are a few people online that want you to know that you're a great speaker.
Oh, thank you.
Okay.
Thank you.
All right, next. Susan writes, what criteria warrants decides medically whether you place a patient on Aubagio versus a Lemtrada?
I mean, those are, so when you're thinking about, risks and benefits, I mean, I would say, Aubagio, you've got an oral medication that is modestly effective and has a pretty good safety profile. Lemtrada, you've got a drug that is highly effective but has a lot of more safety considerations. So those are almost very different ends of the spectrum when you think about things. So the patient's going to have a lot of say in that. How aggressive their MS is going to be very important in making that decision. So it's not that one is clearly better than the other. Those are just two very different drugs with very different safety profiles and efficacy profiles.
Great, thank you. Next, Clarissa writes, as far as new lesions are concerned while on a DMD, would you expect 1 to 2 new lesions per year to be a normal or even acceptable?
I would say 0 lesions is acceptable. We would like to have complete control of your MS. A person without MS, who has relapsing remitting MS, accumulates 1.5 cubic centimeters of new lesions per year. So if you're still accumulating that and you're on treatment, you can say, well, I'm really not doing much better than the natural history. So again, there are a lot of variables in there, but we would like to tolerate no new lesions on MRI.
Okay, thank you. Next, person writes, do you find that people on Ocrevus tend to get worse even on Ocrevus if they're walking versus not walking?
So realize that Ocrevus is approved for both relapsing remitting and primary progressive, and I would say that I'm more impressed with what Ocrevus does in relapsing remitting than primary progressive. We certainly use it in primary progressive. That really speaks to that concept of loss of neural reserve. People can get worse even when they're on highly effective therapies like Ocrevus, and then we have to ask, is this true disease progression or am I progressing because of just normal human aging processes? And it's a tough one. I would say that in that setting, physical therapy is our best friend.
Good afternoon, Dr. Thoreau.
Good afternoon.
For that person that wants to check their antigen level, is it best to go to your physical therapist or go to your neurologist?
So you mean the COVID antibody levels?
Yes.
So that's going to be either through your neurologist or your primary care provider. Either one can order it. Super simple. We use the Mayo Clinic assay. It usually comes back in 48 to 72 hours.
So that's just a blood test?
Correct, simple blood test.
Okay.
It's going to come back as either a positive or negative. If you're negative, that's pretty self-explanatory. You have no antibodies. If it's positive, you need to scroll down and look at the numeric value. Most labs go to great lengths to say we don't know what number is absolutely protective from COVID, but most of us are using a value of around 500. We'd like to see antibody levels of 500 or greater to say that you've got some kind of protective response.
Okay. I was just asking, since we're in this COVID industry now,
Yep.
we got to protect ourselves.
Correct.
Okay, thank you. Next.
Is there anything you can do to restore your residual brain reserves?
So we know that you can build your reserve by just cognitive activities, so things like reading, challenging yourself cognitively. We can build reserve by challenging ourselves physically, staying in an active physical therapy program. So that helps you have more reserve to begin with. Restoring lost reserve, that's where we get into this whole arena of neural repair research. And again, we don't have it yet, but we think we will have it in the future. I will say, just along this, just one little side note. So when we think about restoring neural reserve, one other way of kind of along the same lines is neuroplasticity. So how do we reroute? So I've got an area of damage in my brain or spinal cord, and maybe I can't fix it, but I can reroute around it. The FDA did just approve a device called the Pons Device, which is a neural stimulator. In 2 studies, these were very small studies, people with MS who participated in physical therapy who used the Pons device, and it looks like a little headset, and what would be a microphone is a tab that goes under your tongue. That is an electrical stimulator. The theory is that it's promoting rerouting or neuroplasticity. People who wore that device and participated in very aggressive physical therapy had more improvement in function than people who just got the therapy alone.
Okay. I had a question. Would you consider the B-cell therapies the most aggressive that are FDA approved today?
I think that when I look at the top of the food chain in terms of effectiveness, I would say, in my opinion, you're looking at the B-cell therapies, natalizumab, Tysabri, and Lemtrada, and then you've got a lot of things that are really effective that kind of cluster, just in my opinion, just under that. So Mavenclad, the S1P drugs, I would say, are just right under that. And then you've got our older therapies. You've got your Copaxones and interferons and things like that. But I think probably at the top of the food chain would be our infusible therapies.
Okay, thank you. Back to the online questions. A person asks, longer appointments with GPs needed, along with a better understanding of MS when it comes to urgent care when treatment or infections are required. How can you help us?
That's a challenge. So, ideally, I mean, there's a fine line. You want to have a primary care provider who partners with your MS team, and you don't want them to blame everything on your MS. You go in with a sore throat and they say it's your MS. On the other hand, you don't want them to ignore your MS. So I wish there was a perfect answer for that. There is a lot of trial and error that goes into finding the perfect primary care provider. Word of mouth, talk to your support groups, talk to other people. Who are you using as your primary care physician? If you've got a pharmacist that you trust, talk to pharmacists. Pharmacists see everything. They see all the prescriptions coming through. They know a lot of stuff. Using a website called vitals.com, if you've not looked at it, I kind of jokingly call it Angie's List for healthcare providers. Vitals.com gives you real consumer ratings of healthcare providers, and you can type in anything: family practice, internal medicine, neurology. Type in how much of a search area you want to go, no more than 25 miles from your home, put that in there. They will tell you what insurance companies they work with and whether they're accepting new patients. So yeah, it takes a little detective work sometimes.
Great, thank you for that. All right, Brenda writes, I've heard Dr. Thrower indicate that Evusheld is not necessary to continue getting COVID booster shots. Is that also true regarding upcoming? She says not necessary, but I think you would necessary. All right, is that also true regarding the upcoming BA.5 booster? It sounds like as long as I keep up with the Evusheld 6-month shots, that additional COVID vaccines may not be necessary.
That is my opinion. So I think if you've had Evusheld, the indication is that it appears to be effective against the Omicron subvariants. Obviously, COVID evolves, and whereas Regeneron, the COVID monoclonal antibody, was great against Delta and original COVID, it's not so great against Omicron. We don't know what COVID is going to throw at us next. So I think for right now, as we're here tonight, if I had Evusheld, I probably would not do any more boosters. We need to stay up to date, though. If COVID throws something different at us that isn't covered by Evusheld, we may be back to square one again.
Okay, thank you. Next, what can you tell people that are suffering from stress and anxiety and having problems sleeping? They want to know what herbals might be out there that they can try.
Depends on which herbals you're talking about.
Yeah. The ones that are legal in Georgia.
So the ones that are legal in Georgia, so CBD, so all CBD products are hemp-based, and by law they can have no more than 0.3% THC. So I think they do have a calming effect for a lot of people. If you're having trouble going to sleep, turning your brain off, CBD at bedtime, I usually have people get I like the edibles more than the oil. I think it's easier, just pop one out of the container. I usually have people start with 15 to 20 milligrams of CBD at bedtime. If that does nothing for you, you might try doubling it, but I probably wouldn't go much higher than about 30 to 40 milligrams. It gets too expensive if you try to take more than that. There is a quirky phenomenon out there, and I don't know quite what we're going to do with this yet. So if you go into a CBD store anywhere in the United States, you will see a product called Delta-8 THC. Delta-8 THC is the cousin of Delta-9 THC. It is isolated from the hemp plant. It appears to have a lot of the same biological properties as Delta-9 THC. You take enough of it, you can get high from it. Why is it legal? So why can you buy Delta-8 THC whereas Delta-9 is still regulated? It's legal because the DEA has not said it's illegal. Something is only illegal if the DEA has written a law and regulates it. They've not gotten around to writing a law for Delta-8 THC. So it's a weird loophole right now. I would just say use your discretion. If you're buying a Delta-8 THC to try to treat anxiety or treat other MS symptoms, know where it comes from, know that it's laboratory tested. And hopefully you're not going to a convenience store or a gas station, buying it there. So you just use reputable sources.
I've had relapse remitting for 12 years and do not feel that my neurologist is doing enough to help me. What other options do I have?
Get a new neurologist, I guess.
Exactly.
I mean, and we say that flippantly. I mean, here in somewhere like Metro Atlanta, you have a lot of choices. Some parts of the country, you don't have a lot of choices, and so people sometimes have to get creative. One of the things that I've seen people from outlying areas do, maybe they have a community neurologist who treats a lot of different things. Maybe that's their base neurologist, and they go to a comprehensive center once or twice a year just to bounce ideas off of people. And hopefully those two teams then will coordinate with each other. I know most comprehensive MS centers, we're completely comfortable partnering with a local person and sending them information, helping give them guidance. So yeah, if you're not getting what you need, you need to advocate for yourself.
Okay, thank you. And before I let you answer the next question, I'm going to make mention to this person as well. Person writes, we have no MS-trained neurologist until you travel well over 4 hours away. Well, while I finally found a very good one, I only get to see her once a year. This is very limited, and I have many unanswered questions throughout the year. So whoever did write that, and if this person's online before I give it to Dr. Thrower, you need to watch a lot more of our programs, and you'll get your answers, or you can come on here and ask your questions. All right, now I'll give it to you.
No, I like that answer.
Okay.
You can, if you're only seeing your MS healthcare team, say once a year, ask them if you can set up a longer appointment. So like in our system, we have 30-minute follow-ups and 1-hour new patient appointments. If someone says, you know what, I'm not getting all my questions answered in 30 minutes, can we schedule a 60-minute visit? A lot of systems will allow you to do that. And so you just have more time to come in. They're going to generate a higher code to your insurance company. Eventually that's limited at some level, but just ask for a longer appointment if you can.
Thank you. You spoke about neuroplasticity earlier, and this person at age 68 wants to know if it'll take longer for he or she to learn or he or she to get their brain to learn better at that age.
I mean, our brains are not as plastic and resilient at 70 as we were at 20, but that varies a lot from person to person. There are individuals in their 90s that are still as sharp as they were, and so there is a lot of variability. I think the more we use our brain, both cognitively and physically, the more likely it is that it stays healthy and plastic. So I would never give up on somebody. 68 is not ancient, mainly because it's only 8 years away from me. So I would say keep on plugging away. You're
5 for me.
You're in the same boat.
There you go. Next.
Good evening, doctor. I just would like to know something about multiple sclerosis that is not relapsing MS, but a progressive. Could you just inform me a little bit about it?
So there are two forms of progressive MS. So there's primary progressive, which is about 10% of the MS community globally. And so that's MS that starts from day one as progressive and always stays progressive, no relapses. And then there's secondary progressive. So untreated, people with relapsing remitting MS will move into a secondary progressive form. 10 years after diagnosis, about 50% of people untreated with relapsing remitting MS will move into a secondary progressive form. When you look at the pathology of primary and secondary progressive, they look very similar. So there's not as much inflammation, there's more degeneration of cells. Progressive forms of MS have been very, very challenging, both for people living with them and for treatments, because when you think about ultimately what our disease-modifying therapies do, most of them are anti-inflammatory. And if there's not as much inflammation with a progressive form of MS, our target is just not as big to shoot at. So really with progressive forms of MS, we need to focus more on that neural repair, neuroplasticity, regeneration to really address that problem.
Next question's back here.
When you're talking about a CBD THC 1-to-1, what is the amount of what's the 1-to-1? Is it?
So that's the ratio. So the milligrams are, so you'll look at the bottle. So let's say that each dose of, whether it's a gummy or an oil, has 10 milligrams of CBD and 10 milligrams of THC. That's a 1-to-1, so it's equal amounts of both. And when you get into the ratios, you can do a lot of research. You have to do some trial and error on your own. Most people believe that the higher CBD amount, so if there's more CBD than THC, we think it might be a little bit more sedating, a little bit more calming, so maybe that's something you would use more at bedtime. If it's got more THC in it, you have more potential to have the psychotropic effects. So, if we're using cannabinoids to treat MS symptoms, just like any other symptomatic treatment, you want to treat the symptom without getting side effects. And one of the side effects of cannabinoids, the THC, is going to be the potential to get high from them. So we're trying to minimize that and get the benefit. So that 1-to-1 is just the relative amounts of, but it doesn't specify the milligrams.
How about if you're using it like in a cream for pain?
So I think topical cannabinoids are awesome. So if you've got dysesthesias, burning, hypersensitivity in your feet, just a topical CBD could be wonderful. The side effect risk is just about nothing. Most of the topicals tend to be either CBD alone or CBD with very little THC. Even Walgreens sells a really great CBD topical. So yeah, I'm a big believer in those for limited pain. Obviously, if it's a whole leg or half a body that's bothering you, it's going to get a little bit inconvenient to try to use a topical.
Before I go over to the next person over here, about the 1-to-1, I know that different companies have different grams per that 1-to-1. And how do you know when one is too much?
The general rule of thumb with cannabinoids is start low and go slow. So you don't want to overshoot. Again, if any of you have ever had too much THC, it can be unpleasant for people. You can have paranoid reactions. As we've used more cannabinoids to treat different things medically, we're seeing more of something called a cannabinoid hyperemesis syndrome. This is nausea and vomiting that goes on and on and on for hours, and it doesn't respond very well to things like Phenergan and Zofran. Normally we think of that in people who chronically use too much THC, but you can see it in the person who just does a one-time too much of a dose. So, if someone's never used a gummy, I would tell them, probably 5 milligrams of CBD and THC to start off with, see what it does. If it does nothing, that's okay. Next time we'll try to go up a little bit higher, but you don't want to overshoot right out of the gate.
Good evening, Dr. Thor. I want to know about symptoms. I guess some main symptoms, because during my wife's pregnancy, the doctor told us those were some of the symptoms that happened to her, but you can't really check her because she's pregnant. So just hit on that. Huh? What are some of the symptoms that you look for?
So 2 issues there. I mean, just general symptoms with MS. If you had to say, well, what's the most common symptom we see with MS? The most common symptom people with MS experience is fatigue. That's tough because fatigue is pretty nonspecific. There are a lot of different health conditions that can cause fatigue, but statistically, that's the most complained about symptom in people with MS. After that, it would be sensory symptoms, so numbness and tingling, and then you go on down the list. I mean, weakness, visual, optic neuritis would be a common MS symptom. Pregnancy is an interesting phenomenon for women with MS. So when a woman has a developing baby, she has a foreign body in her body, and her immune system has to tolerate that foreign body. So we joke sometimes that pregnancy is one of the greatest MS therapies there is. And so we think what drives that protective effect of pregnancy is an estrogen called estriol. Women don't have a lot of estriol except during pregnancy. So you get the 9 months typically of a protective effect of pregnancy, and then there's a little higher risk of relapse for the 6 months after the baby's born as those estriol levels are dropping. So that is an area of a lot of research. How can we tap into that as a potential MS therapy? There are researchers around the country. Rhonda Voskuil, for instance, out in California, has been researching estriol for quite a while, trying to see can we tap into that as an MS therapy.
Great, thank you. Next over here, how often do you feel MRI is necessary, especially if a patient is stable and on maintenance medications?
So the politically correct answer is once a year. So typically, we're doing once a year MRIs, brain, maybe the cervical spine. Thoracic spine we do probably less of, just because it adds a lot of time in the scanner if we do all 3, and it's technically one of the more difficult areas to look at. If that person has been stable for 3 years, 4 years, 5 years, we do start having discussions with people about backing off on MRIs. Maybe we go every 2 years or 3 years on the MRI. There's a lot of give and take in there, and there's no absolute right formula. Some people like the security. They sleep better with having a yearly MRI. They like knowing nothing's changed. Other people hate getting an MRI scanner. They have claustrophobia. Their spasms act up. They've have a huge copay with their MRI. So there's a lot of give and take with that. There is a move to do in stable individuals to start doing less contrast. So as MRI technology has gotten better, in a lot of stable people, we're really seeing what we need to see without the contrast. So I would say in stable individuals, most of the time we're doing just MRI, brain and cervical without contrast. It saves you getting stuck, saves the expense of the contrast, and just makes things a lot easier.
So thank you for that. You hit on something, though, while you were just answering that I will have to ask for everybody out there that's going to have that question. For those that cannot pay that copay, what do they do?
Yeah, so there's a lot of financial assistance programs out there. So MSAA has the MRI scholarship program, definitely worth looking into. If that doesn't work out for you, I would definitely talk to your treating healthcare team, see what ideas they have. So for somewhere like Shepherd, for instance, we have our own internal financial assistance program. So anything we do within the walls of Shepherd, whether it's MRI or doctor visits or physical therapy, the person may qualify to have all of that written off for them. So just ask lots of questions. If you're paying out of pocket, if you don't have great insurance or you have no insurance, maybe you're paying for the MRI completely out of pocket, maybe you make too much to qualify for the MSAA, ask for discounts. Say, if you're going to a facility, say, what is the rate that Medicaid pays you for an MRI? I'm paying cash out of pocket. Can I pay you that rate? And a lot of times you can cut yourself a discount.
Great, thank you. For those that have been using telehealth around the country and speaking with a doctor that may be in another state, what will they be able to do? Will that still be covered going forward?
That's a good question. I don't know the answer to that. So if in my mind, insurance companies would be very smart to keep telehealth going. It saves money. It's convenient for patients. Not all visits can be done by telehealth. You know, there are times we need to draw labs or get an MRI or see the physical therapist, but a lot of visits can be done by telehealth, and it's convenient all around. We'll have to see what the insurance companies are going to allow. So far, we've not had anyone at our facility tell us that we can't do it. So we've been able to do telehealth in anyone we want to so far.
Okay, thank you. What can you tell us about myelin regenerating medications? When are they expected to occur?
So most everything in the myelin repair arena, I would say, is in the phase 1 or 2. So these are early trials. And so I would say we're at least 6 years out from probably having something. Now the wild card in all of that, what could come sooner? What if we get something from that micropillar array where they're screening already FDA approved drugs? So let's say clemastine works out, that in a larger study it's shown to be effective. We don't have to wait for FDA approval for that. It's already FDA approved. We would just be using it off label. So if one of those therapies works out and it's already an FDA approved drug, that could be much faster.
Great, thank you. From online again, is gadolinium unsafe when used in MRIs 5 years in a row?
So there are certain, if you have altered renal function, if your kidneys aren't working normally, we have to be very cautious about gadolinium because that's how it gets out of the body. And there are some side effects that you can see with gadolinium in people with poor renal function. There is some indication that some forms of gadolinium may be sticking around in the human brain longer than we knew that they were. We don't know of any side effects that go along with that, but in fairness, we don't know. And so I would say, lots of people with MS have had yearly MRIs with gadolinium going back decades, and I've never seen any side effects from it, but we're trying to be more mindful of it. If we can get the same information without the gadolinium, I would say, let's, as a healthcare community, we need to be more mindful of keeping the gadolinium down and only use it if we really need to. Early in an MS diagnosis, you probably need a few MRIs with contrast just so we get a good baseline, make sure we've really put the fire out. But after that, when you're stable, I think we can drop the gadolinium.
Okay, thank you. Going back to PPMS, is it expected in a certain time frame after a person is diagnosed that they will succumb and get worse?
Primary progressive MS does progress in most people, but it progresses at incredibly varying rates. I have individuals who've lived with primary progressive MS for 30 years and are still ambulatory and very active, and they've never been on treatment. I have individuals with primary progressive MS who are using a walker, scooter, or wheelchair 10 years after diagnosis. So there is a lot of variability from person to person. I would say most people are probably somewhere in between those two.
Okay, thank you. A person wants to know, how can a person start a support group in their area?
So you can partner with any of the nonprofits, National MS Society, Multiple Sclerosis Foundation, MSAA. Talk to your local leaders. There's some geography, and these groups are stronger in some areas than there are in others. But find out who's the big player in your area and reach out to them. Most of these organizations do require some training for peer support before you go out and start up a support group. So that's if you want to do it by the books. I would encourage people, take advantage, because they're going to help you with training materials and really set you up with resources. We do have people who just do it on their own. They're not affiliated with any group. There's one in Macon that I think is still around called Hope Floats that for I think a while may or may not have been affiliated with anyone. So there are some freelance operators as well out there.
Okay, thank you for that. All right, next. Wow, so we got rising fuel prices and people can't afford to see their neurologist because maybe they live a couple of hours away. Is there anything out there for them that they can get reimbursement?
There are. I would talk again to your nonprofits. So there are some transportation grants that can be given. Talk to your facility itself, the MS center that you're working with. So for instance, at Shepherd Center, we have these odd little pots of money where we may have a donor come in and say, you know what? I want to help someone out with things that don't get covered, like gas money or paying their rent if it's not going to get paid. So you just have to ask lots of questions, and then looking at telehealth. Is it possible that my in-person visit could be converted to telehealth and save me that drive in?
Okay, you were saying that MS is not hereditary, but I've known 2 family members to have MS, same blood.
So I didn't say MS is not hereditary. So I would say MS has a genetic component, but it's not strongly hereditary. So if you have MS, your first-degree relatives have about so your brothers, sisters, parents, children have a 2.5 to 3% chance of having MS in their lifetime. So that's higher than the general public. So there is a genetic component, but when I'm counseling a new person, let's say I'm a mom or a dad, I'm newly diagnosed and I don't have kids yet, I tell them there's a 2.5 to 3% chance that your child could have multiple sclerosis. In the big scheme of things, I tend to be an optimist. And I would say there's a 97.5% chance that your child's not going to have multiple sclerosis. And if you're a parent, there's a lot of things I would worry about before I would worry about my kid getting MS, getting hit by a car, all kinds of other things that could happen that are much more likely than the person getting MS. I do advise that if mom or dad has MS, that when the child is about 3 years of age and they see their pediatrician, that they get their vitamin D levels checked. That's one of the controllable risk factors that we have. So if a kid has low vitamin D levels, let's get them on something to correct that early in life. They make gummy forms of vitamin D that a toddler could take.
Okay, thank you for that. Next one, concerning spasticity, what complementary therapies are there? And also, what do you tell for people that have like leg rigidity in the middle of the night with extreme pain and it hurts so much that they can't even get up and walk?
Yeah, so one of the frustrating things about spasticity and spasms is they tend to act up more at night. When you're trying to rest, you're trying to get to sleep, and they're just going to really kick off. A lot of people, as they're going to sleep, the legs just start running a marathon. When you don't want them to. So the base for managing spasticity and spasms is stretching, and more stretching. You can't stretch too much, so we want to make sure we've got that base covered. You can work with a physical therapist and have them give you a good stretching program. There's another form of stretching out there called dynamic stretching. Normally when we think of stretching, what we're doing is static stretching. We're moving our limbs, our leg into a certain position and we're holding it there. Dynamic stretching means you're stretching while you're moving it. So there are a lot of facilities that you can go to. If you go home and you Google dynamic stretching near me, you'll find these places. There's a franchise called the Stretch Zone. Massage Envy offers this. So this is something that you could go and do once a week, every couple of weeks, and it just gives you a different way of getting a good stretch in. Insurance is typically not going to cover it. It's going to be an expense out of pocket for you. We talked about cannabinoids. I would put that in kind of the alternative complementary therapy realm. And then just, realize that we have a toolbox for managing spasticity and spasms. We know people would like to avoid prescription drugs sometimes, but sometimes we do have to look at some baclofen or tizanidine at bedtime. If you're having primarily nighttime symptoms like they're describing, one of the side effects of baclofen and tizanidine is they tend to be sedating. They're great bedtime medications because we're not going to worry about that sedating side effect with just a bedtime dose.
Okay, thank you for that. What about excuse me, it's summertime. Are people more affected with spasticity because of the heat?
So 70% of people with MS have heat sensitivity, and it's going to be unique to you. So when you get overheated, maybe in one person their vision dims out, maybe in someone else they get fatigue, someone else their legs get noodly, in someone else maybe it's spasticity and spasms. In my experience, if a temperature variation is going to worsen spasticity and spasms, it's more likely to be cold than it is heat. And so some people with MS have cold sensitivity just like they have heat sensitivity, and then we have some people who have both, so they've got this really narrow little temperature range where they feel good and they have varying symptoms at the extremes of either end.
Okay, so for that, you mentioned baclofen and some of the other FDA approved. You mentioned CBD. Is there anything else that a person could take that's complementary?
So complementary, the cannabinoids as far as an oral medication would be what I've seen the most luck with. Magnesium, some people will, I'm more impressed with magnesium for managing migraines than I am for spasms, but I do have individuals say that a little bit of magnesium oxide, 400 milligrams a day, does sometimes help with their nighttime leg symptoms.
What about for all those that say eat more bananas?
So that's potassium. There are people who are potassium deficient. That's usually not what's driving spasticity and spasms in MS. Now, if you're on a diuretic like Lasix, then you've got two different issues, and so then the potassium for the bananas might help. I worry a little bit about a lot of bananas in people with MS just because they tend to be constipating, and a lot of people with MS are already kind of dealing with that, so I'm trying not to add that fuel to the fire.
Okay, thank you. So here's an interesting question. You mentioned that MRI should be done once a year. How often should a person see their neurologist, and how often should that same person see all the doctors that neurologist suggests that person sees?
Boy, that's a big question.
It
so
is.
How often you see your neurologist is really going to depend upon what your MS story is. So if you're on Tysabri, we're seeing you every month at that point. And so like in our Tysabri patients, they're coming in monthly, they're having a provider visit every 3 months. There are certain medications that require every 3-month visits, your stimulant drugs like your Adderalls and Ritalins. The average person with MS is probably going to have a twice-a-year visit. And in a lot of centers, what that's going to look like is you're going to see the neurologist one visit and the advanced practice provider, the PA or the nurse practitioner, the other visit. Maybe we throw in some extra visits urgently if there's something new that's going on and we need to get you in quickly. So the average person, I would say, is twice-a-year visits. Some of our super stable patients, we get down to once-a-year visits. In terms of referring you out, that really is going to be dependent upon what we're referring you out for. So if you're seeing if I think you have sleep apnea contributing to your daytime fatigue, well, that sleep doctor is probably going to see you a couple of times a year to coordinate your, if it's sleep apnea, your CPAP and whatnot. I really think it's vitally important that people with MS do have a good primary care provider, though. There's as comprehensive as places like Shepherd are, we really shouldn't be your primary care provider. I've always said if your neurologist is your primary care provider, you have a bad primary care provider. We are not up to date on routine health screenings, mammograms, colonoscopies, prostate. Those are things that need to be taken care of. People with MS don't tend to die from MS. People with MS die of heart disease, cancer, and stroke. So we want to make sure that we're dealing with your MS, but don't lose sight of the other health issues, that can affect your life while we focus only on your MS.
Thank you for that. We have a question back here in the audience.
Dr. Thora, I have a question in regards to something that I'm experiencing personally. It's similar to neuropathy with those persons that have diabetes, but I don't know exactly what it is. It's on my right foot ankle. There's like a nerve pain, if you will, that happens, and it happens whenever it needs to. I did call my neurologist. They say gabapentin. I don't like to take that because it makes you feel loopy, if you will. I don't know exactly what that is.
So the symptom is very, very similar to what we see with peripheral neuropathy, and sometimes neurologists mistakenly use the term neuropathy to describe that. Technically, when we say neuropathy, we mean something affecting the peripheral nerves. The symptoms that you're having with MS are coming from lesions upstream, brain or spinal cord. So people have used the term central neuropathic pain to describe that, or a dysesthesia. So if you have a funny extra feeling, you feel like water is running down your leg when there's nothing there, that's a paresthesia. If your paresthesia becomes uncomfortable or painful, then it's a dysesthesia. So it's from your MS. When people have localized pain, it's a pretty limited area. That's where maybe topicals could be used. So something like the CBD lotion or creams, if it's just a small area that's involved. Even lidoderm patches, so that's a prescription patch. It's about that big, transcutaneous lidocaine. Over the counter, if you look over where like the topicals are, there's Salon Pause. Salon Pause makes a 4% lidocaine patch if it's a small area of pain that you're dealing with, you could try something like that as well. So, I hear you on the gabapentin. That's usually our go-to. We joke sometimes that neurologists would put gabapentin in the water supply if we could, because it treats everything. But a lot of people don't feel so great when they take gabapentin. They feel lightheaded, woozy, drowsy. There are other oral medications that are options as well. Things like Lyrica, even some of the antidepressant drugs, things like Pristique or venlafaxine can sometimes be used for pain, but we generally would like to use the least offensive thing we can, and if a topical would do it, that would probably be what I would start with.
Great, thank you. I got two questions. First one is, what can you tell us about fatigue, and what can we take for this, please?
Fatigue, number one symptom complaint in multiple sclerosis, comes in two flavors: lassitude, which is non-exertional, non-heat related fatigue, and then there's nerve fiber fatigue. That's the heat related exertional type. So with lassitude, we want to make sure we're not dealing with something else. If you're having inadequate sleep, you're going to have inadequate energy levels in the daytime. So sometimes what looks like primary MS fatigue really is a sleep issue. We need to address that. We don't want to be revving your engine if there's no gas in the gas tank, and you don't have gas in the gas tank if you're not getting adequate sleep. So look at sleep. If it's not that, then we have things that manage the lassitude directly in the daytime: amantadine, Provigil, Nuvigil, true stimulant drugs, your Ritalin, Adderall type medications can all be used there. Nerve fiber fatigue, the heat, exertional related stuff, manage the heat. Cooling vests, stay out of the heat, drink lots of cold liquids. And then dalfampridine or Ampera is something that tends to work for nerve fiber fatigue to improve walking. And then there's the non-FDA approved version of that, the compounded version, 4-aminopyridine, that can also be used for nerve fiber fatigue type symptoms.
That's great. Thank you for that. So my final question for everybody is, who liked listening to this guy? Right?
Thank you. Thank you. Thank you.
Okay, good. Thank you. And who wants to attend another one of these? Hopefully you won't hit all that Atlanta traffic, right? Well, we're hoping that sometime next year we could do a symposium with a multitude of speakers at that program like we do in South Florida. And, we're going to want you all to get the word out there for everybody, because we're going to want to see over 100 people at that program, okay? And no Atlanta traffic.
Yay.
Okay, great. All right, so with that, I'm going to say goodnight to all of you online, and then I'm going to come back to my local audience, all right? So goodnight, all of you online. We'll see you next time.